64-year-old male received single lung transplant on January 9th for interstitial pulmonary fibrosis. His initial hospital course was uneventful. He was readmitted to the cardiac ICU for hypoxia twice. On February the 2nd, he was extubated. On the night of February the 2nd, the patient became increasingly somnolent, then agitated. He ripped out his arterial line. Haldol was given. A few hours later, on February the 3rd, patient had a 2-minute self-sustained grand mal seizure, which consequently led to his reintubation. As you can see, his tacrolimus level ranged between 8.9 and 15.1 the week of January 22nd, and 9.7 and 12.6 the week of January 29th. On physical exam, patient was afebrile, regular rate and rhythm, no murmurs, gallops, or rubs. He had breath sounds bilaterally, and was initially somnolent and then appeared agitated. Brain MRI revealed bilateral occipital and parietal occipital and subcortical white matter T2 signal abnormalities that were consistent with posterior reversible encephalopathic syndrome, or PRES. I have divided this lecture into 6 sections. We will first give a general description of what PRES is. We will discuss the different etiologies and pathophysiological mechanisms. We will illustrate the common signs and symptoms, how it's diagnosed, and lastly, what treatment options exist. Generally speaking, PRES is an acute encephalopathy related to edema within the brain parenchyma, usually isolated to the cerebral white matter. For the most part, the posterior parietal temporal occipital regions of the brain are most commonly affected. The causes of PRES are diverse, but common precipitants are acute elevations of blood pressure, renal decompensation, fluid retention, and treatment with immunosuppressive drugs. In approximately 70 to 80% of patients, moderate to severe hypertension is observed, but approximately 25% of patients don't have high blood pressure. Most authorities believe that hypertensive encephalopathy and eclampsia share similar pathophysiological mechanisms. PRES most commonly affects the white matter area of the brain. Histologically, the white matter contains the axons, which are lipid-rich, containing activated reactive astrocytes, scattered macrophages, and lymphocytes without inflammation, ischemia, or neuronal damage. Late autopsy studies, however, have generally demonstrated evidence of ischemia, neuronal anoxic damage, laminar necrosis, or older hemorrhage in the white matter and cortex. PRES has been studied in preeclampsia patients. Laboratory evidence of endothelial injury is often present with platelet consumption and evidence of red cell fragmentation. The cause of PRES is not entirely understood. Catheter angiography shows diffuse vasoconstriction, focal vasoconstriction, vasodilatation, and even a string of beads appearance have been noted, consistent with what is typically described as vasospasm or arteritis. The blood-brain barrier is the interface between the cerebral circulation and the brain extracellular fluid. This barrier occurs along all cerebral capillaries and consists of astrocytic tight junctions not found in normal circulation. These vascular endothelial cells restrict the diffusion of small and large molecules into the cerebral spinal fluid and partake in the active transport of metabolic products. The vasoconstriction seen in catheter angiography prompted investigators to postulate that reduced brain perfusion led to imaging features. In contrast, animal studies suggest that experimental sudden elevations in systemic blood pressure above the autoregulatory capabilities of the brain vasculature led to hyperperfusion and breakdown of the blood-brain barrier, causing focal, transudation, and petechial hemorrhages. With posterior reversible encephalopathic syndrome, capillary leakage and acute disruption of the blood-brain barrier occurs, causing white matter edema. It is this edema that can cause headaches, alter mental status, and seizures. The mechanism by which immunosuppressive therapy can cause PRES is less clear. Hypocholesterolemia, hypomagnesemia, high-dose methylprednisolone treatment, aluminum overload, and drug levels above the therapeutic range are some factors attributed to the neurotoxicity seen. The direct effects of cyclosporin on the central nervous system has not been established. However, cyclosporin and its metabolites have been found in the cerebrospinal fluid of liver transplant recipients, which suggest a perturbation of the blood-brain barrier. Specifically, it can induce injury and dysfunction of the endothelium, leading to enhanced vasoconstrictive effects. Tacrolimus neurotoxicity has a similar mechanism. Of note, the rate of tacrolimus-associated PRES appears to increase with the degree of graft mismatch. Immunosuppressant blood levels do not appear to correlate with the severity of neurotoxicity, or PRES, but immunosuppressant discontinuation or switching of the immunosuppressant usually results in clinical improvement. Most patients have a change in alertness and activity. Lethargy and somnolence are often the first signs noted. Temporary restlessness and agitation may alternate with lethargy. Stupor and frank coma may develop, but usually patients remain responsive to stimuli. Seizures may begin focally, but usually become generalized. Multiple seizures are more common than single events. Abnormalities of visual perceptions are nearly always detectable. Patients often report blurred vision. The most common location and abnormality on neuroimaging was edema, involving the white matter in the posterior portions of the cerebral hemispheres, especially bilaterally in the parietal-occipital regions. Although MRI yielded a higher resolution image, it was not necessary for diagnosis. Radiographic diagnosis can also be apparent on CT scan. Hemorrhage is seen in approximately 15% of patients. The calcinine and paramedian occipital lobe structures are spared, which is what distinguishes it from bilateral infarction of the posterior cerebral artery territory. Studies show that in rats that were made suddenly hypertensive, PRES signs disappeared within hours after the hypertension was relieved, suggesting that functional vascular changes and edema were the chief causes. PRES is readily treated by controlling blood pressure and discontinuing the offending immunosuppressive agent or decreasing their dose.